Hello, and welcome to my evidence evaluation presentation for Epidemiology and Research Principles at the University of Canberra. The intervention I have chosen to investigate is the use of dry needling as a treatment for patients with myofascial pain syndrome. Myofascial pain syndrome is a very common presentation at physiotherapy clinics. It is caused by localized, highly irritable hyperalgesic zones of muscles known as trigger points. Trigger points are hypersensitive areas that, when palpated or manipulated, can cause varying degrees of pain. The pain can also be brought about by and hinder functional activities or exercise. The cause of trigger points and MPS is often an acute overload, acute injury, or repetitive microtrauma. As you can see on the picture in front of you, one band of muscle can have multiple painful trigger point areas, highlighted in red, that need to be treated. Dry needling is a controversial emerging technique. It involves the physiotherapist singling out the painful trigger point areas and inserting tiny acupuncture needles, as seen in the picture, into the site until the trigger point is inactivated and relaxes. The actual mechanism of pain relief is still under debate. It is thought that the insertion of needles directly into the trigger point elicits a localized twitch response that in turn relaxes the actin-myosin bonds in the tight bands of muscles. The localized twitch response that occurs is also thought to interrupt the motor end plate noise, which can produce an analgesic effect. Physiotherapists are at an extremely high risk of hand injury. These injuries are commonly musculoskeletal or arthritic and are more often than not from overuse. By decreasing the load on physiotherapist hands, it could be possible to create a decreased rate of injury and early retirement. If it is possible to increase the longevity of a pain-free career for musculoskeletal physiotherapists, it is worth investigating. The current treatment for myofascial pain syndrome is a variety of standard physio techniques, including deep tissue massage, ischemic massage, ultrasound, heat, stretching, and TENS. Dry needling is not only cheaper and more time effective than the majority of those treatments, but it is also easier for the physio to administer without hand fatigue. If the patient is able to get the same results in a shorter amount of time, with the physio having less load on their hands, this intervention could become a staple in all musculoskeletal clinics. The search strategy used to gather these articles for this evaluation was an online search of multiple databases, including the University of Canberra Online Journal Library, PubMed, Cochrane Review, and Google Scholar. The search terms and conditions were articles from the last 4 years, published in English using the key search words of dry needling and myofascial pain syndrome. Unfortunately, as dry needling is still a relatively new intervention when compared to some standard, well-documented techniques, there is not a wealth of peer-reviewed work on this topic. However, that being said, the articles gathered for this evaluation were still of a moderate strength when using the National Health and Medical Research Council's hierarchy for evidence. There is one systematic review, that being the gold standard level 1 in the hierarchy. Kitries et al. Did a meta-analysis of studies that focused on dry needling therapy versus other techniques, including manual manipulation, pharmacological intervention, and clinical treatments or shams. The next two were level 2 in the hierarchy, being randomized controlled trials. Teakin et al. Did a study that involved dry needling versus sham needling, and Regani et al. Investigated dry needling compared with the standard physiotherapy techniques for MPS. Only the former of these two trials was a double-blind. The quality of evidence surrounding this intervention was of a moderate standard. The research questions were all clearly stated, which left no room for misleading interpretations as to what was being investigated. The randomized controlled trials had clearly stated and well thought out inclusion and exclusion criteria. Inclusion criteria was site and duration of pain, age, and previous treatments. Exclusion criteria was able to exclude other conditions, including nerve damage, that could have skewed the results. The systematic review had multiple reviewers involved in choosing relevant articles after a comprehensive database search. This was able to decrease the possibility for systematic errors or bias. The measured outcomes for the trials were all almost identical, with the only type of scale to measure pain or quality of life changing. Teakin et al. Was able to score a 9 out of a possible 11 on the Pedro scale. The biggest weakness in this evidence was that at this stage there does not appear to be quantitative methods for measuring trigger point reduction. There is only the subjective measure of patient-reported pain levels. I will go further into this along with the lack of blinding in these studies when I discuss bias on the next slide. It's important to point out that the second trial was only able to score a 6 out of a possible 11 on the Pedro scale, which leaves a lot to be desired when discussing the legitimacy of evidence. The biggest source of bias in these studies was the fact that the main measurable outcomes, being pain and quality of life, were extremely subjective and vary person to person. There does not seem to be any relevant way to measure trigger point pain reduction other than this, so it's understandable why the researchers have done so. Pain is very personal. Unlike measurements of weight or height, one person's 10 out of 10 pain can be another person's 5 out of 10, meaning that the outcomes measured, whilst relevant for each person's pain levels, may not be relevant to the population as a whole. As quality of life being affected by pain is also very open to interpretation, this was another source of bias. The occupations and the like of the subjects were not reported, so it's impossible to know how much the pain was affecting their quality of life previous to the treatment. If a physical labourer had results that improved their quality of life, they would have reported a much more dramatic change than a more sedentary person, meaning that the quality of life assessments were relative to the people they were done on, but not necessarily covering the entire population. A person's mood and feelings toward a treatment also have the power to impact how they rate their pain. The next source of bias was that it was impossible to make all the trials double or even single blind. This is because a patient cannot have ultrasound or heat treatment and be told they are having dry needling, as it is not believable as a sham or control and will not work. Similarly, a physio cannot administer these treatments and be told that they are doing dry needling. This means that in some of the non-blind trials, if the patient had an opinion on which treatment would be better or which treatment was likely to work, it could have subconsciously affected their assessment of their pain and whether or not the treatment worked for them, thus inadvertently skewing the results of the outcomes one way or the other. The reported outcomes between all the trials were very similar. Every trial found that dry needling did have a pain-relieving effect immediately, and those trials that did longer interventions and reassessments found that needling worked well over time as well. When compared to sham treatments, for example needling with blunt needles so there was no actual penetration of the skin, it was found that real needling was more successful in inactivating the trigger points. In studies involving pharmacological injections, such as lidocaine, it was found that dry needling may not have as prominent an effect as the drugs. When comparing dry needling to typical physiotherapy techniques such as ultrasound, TENS, massage, heat and stretching, both were found to be comparable in their level of pain relief and improvement of quality of life. The current studies all show that when compared with sham or real physiotherapy techniques, dry needling does have an effect on the pain that's caused by trigger points in myofascial pain syndrome. As this is a very common presentation to physiotherapists, the evidence evaluation here has shown that there is most definitely a cause to do more research into this topic, so possibly with different trials, so that there can be more definitive proof of its success. Thank you for listening.